Alright, pay attention everyone, take the notes. So far we discussed about types of anemias, right? We discussed anemias, we discussed normal values. Then I'm just letting you to know, listen, I hope everyone knows what is erythropoiesis, right? From previous semester. Then I hope you know about what is bleeding time, clotting time. You know what are reticulocytes. Am I correct? Reticulocytes are immature. Immature RBCs are reticulocytes. So all these things are clear, right? So let us go straight to the topic, that is reticulocyte count. Already we discussed, but again I am taking. So what is the normal reticulocyte count? Yes, reticulocyte count normal is 0.5 to 2.5 percentage. So how we calculated reticulocyte count? Reticulocyte percentage is equal to, yes, number of RBCs for unit area and total number of RBC into 100 will give the reticulocyte count. Okay, what is the purpose of reticulocyte count? What is the purpose? Yes, bone marrow. See here. So this is bone marrow. So bone marrow, right? Now listen, condition. So bone marrow is producing red blood cells. Okay. The normal production rate of bone marrow is 100. For example, for 100 cells, we will get around 0.5 percentage of red blood reticulocytes. In normal condition, 100 cells, 0.5 reticulocytes are produced. Reticulocytes are some, escaped immature red blood cells. Okay, this value corresponding to this. Okay, now there is a malaria in the patient, and malaria caused many cells to destroy. Okay, cells has been destroyed in malaria. So the patient became anemic. Okay. Patient red blood cell count dropped to 4 million cells per cubic millimeter of blood. Okay, 4 million. Patient became anemic because of anemia. Then what bone marrow will do now? So, blood RBC count has been reduced. Okay, how much gap is there? 1.5 million cells has been destroyed. Now bone marrow will replace those 1.5 million cells. Am I correct? During anemia, the bone marrow will respond to this condition to release more cells, resulting in production of 2000 cells per minute. This is 100 cells per minute. Now it is under stress. Now the bone marrow is under stress because there is an ongoing anemia. Due to ongoing hemolysis, the bone marrow has, it is synthesizing more blood cells, resulting in increased count, maybe some 4 to 5 percentage reticulocyte count. Reticulocyte count has been increased because the bone marrow producing excessive red blood cells in order to compensate the anemia. Compensate means in order to balance the anemic condition. Is it clear? So reticulocytes giving the bone marrow response to an anemia. Is it clear? When we are counting the reticulocytes, it is showing whether bone marrow responding to an anemic condition or not. Okay? So bone marrow functional status, the functional status of the bone marrow can be evaluated by reticulocyte count. And normal reticulocyte count is 0.5 to 2.5. This is clear to everyone. Now, let me see how best, how well the bone marrow working. Okay, simply bone marrow working is not the thing. Can my bone marrow produce 4 million cells per minute? Is it possible? Or can it produce 4,000 cells when there is a huge anemia? Okay, when there is a huge hemolysis, for example, I given a mismatched blood transfusion to the patient and there is a huge blood loss, there is a huge hemolysis in the body and bone marrow must produce, now there is a more work to the bone marrow. Rather than preparing 1000 meals, now it need to prepare 10,000 meals. Can my bone marrow do that work? I need to check that with anemia, degree of anemia. If degree of anemia is 70%, normal anemia is 20. Okay, but my degree of anemia is 70%. There is a huge hemolysis. Can my bone marrow produce 70% of reticulocytes to maintain the anemic status, to bring it normal? This will give the true representation of bone marrow response to an anemia. Just bone marrow responding not sufficient. That all bone marrow will respond to some type of response by reticulocytes. So what you understood here? In an anemia, there should be more reticulocyte count. That means more reticulocyte count indicates there is some hemolysis in the body and bone marrow trying to produce more cells. This is clear. One relation we understood. High reticulocyte count indicates decreased RBC count or increased hemolysis. This connection is clear, right? Increased reticulocyte count indicates reduced RBC count or increased hemolysis. Everything same. Is this logic clear? Yes. Then second logic. Is my increased reticulocyte count is equal to the level of destruction of hemolysis? My hemolysis is 70%. Can my bone marrow producing 70% of cells now? That I will check with the help of reticulocyte production index. Reticulocyte production index. Reticulocyte production index will check whether bone marrow responding to the degree of destruction or not. Bone marrow responds to the degree of anemia, degree of hemolysis is reticulocyte production index. So in this, to calculate this one, what we are going to do is we will take three values. This I already discussed. What are the three values? First we will calculate the corrected reticulocyte count. Then we will take the maturity index, maturation correction or index. We will take maturity index and we will go for counting the RPI. Okay. So now there is a universal standardized HCT value. What is the meaning of HCT? Hematocrit. Hematocrit is also called as PVC. Indices. Yes, fine. Indices is a collaboration of everything. So PCV, okay. So universally standardized PCV value is 45. Keep in mind. This 45 will integrate later. Okay. There is a normal PCV, normal HCT value that is 45%. Okay. Now we have our first step. Our first step is we are going to corrected reticulocyte count. That means we are not going to follow this formula. We are correcting the formula. 45% is a hematocrit value, a standardized normal hematocrit value. Keep it like this. It's a standard value. There is a standard HCT value that is 45%. Okay. How they standardized it means they have taken surveys of the population and they came with an average value, the mean of human HCT value. Okay. So overall humanity has a ranges. You just keep in mind, we will do some surveys and we will maintain standards. That's why standards will be given by governing bodies like WHO, CDC or local governing bodies like ICMR. Okay, they will use some values. The accepted value HCT is 45. It's a average standardized value given by the WHO. Okay, across the population. Okay, now listen. Now the first step is corrected reticulocyte count. So the corrected reticulocyte count, write down the corrected reticulocyte count, CRC. Corrected reticulocyte count is patients patient's HCT value, patient's hematocrit value, that means PCV value, by normal HCT value. What is the normal HCT value? 45. Okay, by normal HCT value. This will give the corrected this value, whatever value we are getting, that will be the value. Okay, that will be this corrected reticulocyte count. Okay, so this is the formula. Then second, so this will be 45. This can be anything, 32, anything it can be, but this will be 45. This is clear. Then second step. What is the second step? Maturation index. So universally they have given a scale of maturation index. They have given a standardized scale for checking the maturation index. Maturation index means the maturation of red cell or reticulocytes to red blood cells. Reticulocytes to RBC. Yes. Corrected reticulocyte count. Yes, corrected reticulocyte count value we are taking from patient's current HCV, PCV value by the normal PCV value. We are integrating PCV values into the reticulocytes. Why we are integrating PCV, we will see later. Okay, blood volume. First we are taking blood volume. How much blood cells are destroyed, that will give the degree of anemia. Then we are checking the cells, the reticulocyte cells. Okay. Listen, the degree of anemia. I said here, right? How much amount of hemolysis happened? The amount of hemolysis happened, the value will be given by PCV value. PCV will give the degree of hemolysis in the body. The degree of hemolysis will be given by the PCV. So that's why I am integrating PCV into the reticulocytes now. I am comparing PCV with reticulocyte to compare the degree of anemia with the bone marrow response. Is it clear? Yes. If don't take it too complicated, this formulas are easy. Already everything is standardized. We are just integrating PCV into the reticulocyte. Okay. Fine. The second step, maturation index. As I said, they have given a universally standardized scale. Write down the scale values. The standardized scale values are like this. They say if HCT, if PCV value is greater than 35%, if patient PCV value is greater than 35%, then the factor will be, then the maturation factor will be 1.0. Okay, maturation factor will be 1.0. If the HCT value is in between 25 to 35%, then the maturation factor value is 1.5. If it is 15 to 25%, then it is 2.0. If it is less than 15%, then it is 2.5. This is the maturation scale. Okay, maturation index factor scale. Maturation factor scale. So we have a maturation factor scale. This is very important test. Okay, in the diagnosing the rest of the things I will discuss later.
What is the last one?
Less than 15 is 2.5. Less than 15 is 2.5. Okay. Important question for exam also, keep in mind. Okay. Now listen. Now we are going to calculate the RPI, reticulocyte production index. So the RPI is calculated like this. Corrected reticulocyte count by maturation factor. Corrected reticulocyte count by maturation factor. So it will be like this. So corrected reticulocyte index we got 5%. For example, assume we got 5% into 30 by this formula. The patient has 30 by 45 normal value equal to 3.33%. This is the CRC. I got the CRC value. Now from this CRC value, what I will do is reticulocyte production index is equal to 3.33% by 1.5. How I took this 1.5 means 1.5 is the severity of the 1.5 is 35. Okay, actually let me write here. I need to write here maturation factor. Patient PCV is within the range of 30. Patient PCV is 30. That means the maturation factor will be 1.5. I am going to take this 1.5 value here. Okay, I took 1.5 value here by taking the overall percentage of CRC. I incorporated with the maturation factor of his previous HCT value. Then what I did, yes, that's it. This will give the 2.22. This is RPI. The normal RPI write down. Normal RPI value is around 1.0. It should be around 1.0. Then it indicates normal bone marrow response to anemia, to ongoing anemia. If it is less than 1.0, that indicates inadequate response of bone marrow to anemia, to ongoing anemia. Okay. Then greater than 1.0 indicates excessive blood destruction happening in the body. Excessive blood destruction beyond the capability of bone marrow. The level of destruction in the body is too much that bone marrow is unable to compensate with cells. Okay. 1.0. Greater than 1.0 means excessive blood destruction in the body. Less than 1.0 is inadequate response of bone marrow to anemia. Inadequate response of bone marrow to anemia. Inadequate response of bone marrow to anemia. Now let us see. That means, see here students, bone marrow, the bone marrow status has been recognized by reticulocyte count. Am I correct? So reticulocyte count will determine the bone marrow status. If reticulocyte count is less, that means less than 0.5, what it indicates? If reticulocyte count is less than 0.5, what it indicates in the body? Excessive blood destruction. No. When there is a increased, more than 2.5, reticulocyte will say there is an excessive RBC destruction. So there is a increased platelet count, reticulocyte count. Sorry. Okay. What is the decreased reticulocyte count?
Sir, maybe inadequate response to bone.
Maybe bone marrow unable to produce sufficient blood cells. Why my bone marrow is unable to produce cells? What might be the reasons? It might be, one thing will be dietary source, maybe some malnutrition, vitamin B12, all these things leading to bone marrow, not responding. And second one, it might be a plastic anemia. Third one, genetical disorders. That we'll see. It can be anything. We'll see. Genetic problems. Our Shubham saying genetic problems, or there is some issue with the bone marrow. Bone marrow unable to produce reticulocytes. That is a very, very, very dangerous condition. As I discussed now, listen. Now, what happening to our diagnosis of patient? See. First we thought he has an anemic condition. First I saw he has anemia in the eyes. It's simple thing. I did his HB everything. Then I went for his reticulocyte count. Then I understood that there is a lethal destruction of cells and bone marrow not responding to the lethal destruction of anemia, bone marrow not responding to the anemia, then I was trying to understand why my bone marrow is not responding. Is it issue with diet? Then I given vitamin B12. I given B12 and I said the patient to return back after 2 days. Patient came back after 2 days, still his count is less. Still his reticulocyte count is less. Maybe patient might have a genetic disorder. The genetic disorder can be a cancer. It can be an aplastic anemia. Okay, it can, listen now, to diagnose aplastic anemia, what is aplastic anemia? Complete dysfunction of bone marrow. Okay, in aplastic anemia, all cells will be reduced. In aplastic anemia, there will be reduced RBC count, reduced WBC count, and reduced platelet count. This is called as aplastic anemia. Okay, that means the bone marrow is gradually dying. Okay, slowly. Yes, Kalambe. Fine. The bone marrow is gradually destroyed. Okay. I don't know whether you can able to understand the severity of these conditions or not. I will just go through the next slide. Then you will understand. See, wait. So these are the reticulocytes. You already know reticulocytes, right? So reticulocytes, immature red blood cells. I just to show you one important thing, that is this one. Yes, there is a different type of anemia I already discussed with you. That is called as Fanconi anemia. So Fanconi anemia is listen, by the age of 40 years, the bone marrow will be completely destroyed. It's a gradual, slow destruction of bone marrow, and that will be shown by an anemia called, that is Fanconi anemia. These children will die by the age of 40 or 50. Hardly 30 to 40 years, that's it. Unless their bone marrow has been transplanted. But they are genetic disorders. Even after transplantation, the rate of survival of these children is very less. 30 to 40 years, that's it. Maximum 45 years, if God grace. But yeah, this is a different set of anemia. This is an anemia caused purely due to genetic reason. Okay, the bone marrow is gradually diminishing and it died. Okay, this is called Fanconi anemia. This Fanconi anemia will be seen right from the childhood onwards. Okay, so there are some signs and symptoms of recognizing these children. Obviously, these children will show neurological issues. They will have memory loss. All these things can be seen in these children. Okay, yeah. Then, yes, one interesting feature will be their digits will start destroying themselves. Okay, you can see here, their fingers will be lost gradually. Their body eating their own fingers. Their body white blood cells started eating their own cells. Okay, very painful. I don't know what to do.
So there is a disorder. Can you explain this in this term?
SIDD.
SIDC.
Severe
immunodeficiency syndrome.
That we will see later. Okay, I will discuss here only. Severe immunodeficiency syndrome. I will tell. Listen. Then how Fanconi is different from aplastic? Okay. In aplastic anemia, we saw that there is a destruction of all cells. But there are some type of specific anemias where only WBCs will be reduced, but RBCs will be normal and platelets will be normal. Is it possible? Is it possible that RBC and platelets are normal, but WBCs are reduced or increased? That will be a leukemia. Okay. Or in the WBC, there are B cells and granulocytes and granulocytes. Okay. If there is any issue with the B cells are reduced. Then that is called as severely SIDC, severe immunocompromised SICD, deficiency syndrome. Okay, that we'll see later. Now you understood what is Fanconi anemia, to my knowledge. Then then I was these symptoms are really dangerous. As I stated in the last class, if a patient coughing with blood, there is a chance of anemia. there is a chance of cancer. Okay, maybe their bone marrow not producing platelets. So there is an internal bleeding and blood capillaries has been ruptured. Blood capillaries has been ruptured, and there is this one. So a simple blood from a cuff or nose can be a cancer. It can be a bone marrow cancer. Okay. Yes. Never ignore these symptoms. By the way, the chances of getting bone marrow cancer is very less. It is around 0.3 to 1%. Since you got a nose bleeding doesn't mean a cancer. Okay, don't worry. There are many other symptoms that need to be correlated. Don't worry, but this is one sign. Okay, yeah, that's it. So bone marrow, complete absence of bone marrow cells is called as aplastic anemia. You already understood, right? This concept is clear. Then yeah. Then I said something called reversible cause of aplastic anemia. This reversible cause of aplastic anemia means in some conditions purposefully we will destroy the bone marrow of the patient. Purposefully we will destroy bone marrow of the patient, such as in chemotherapy. Okay, because I will give one example of chemotherapy. What I did is, maybe my patient has some cancer. Okay, cancer cells are, what is cancer cells? Uncontrolled cell growth. So I given some tablets, and these tablets are controlling the cells. That also causes the bone marrow to deplete. When I am giving cancer medications, cancer drugs are stopping cell growth, and that the cancer drugs will have a side effect on bone marrow. Now the bone marrow cells also reduce because of ongoing chemotherapy. That looks like an aplastic anemia. Since I given cancer drugs, bone marrow also produced less cells. That looks like an aplastic anemia. Now there is a huge problem. During this chemotherapy, bone marrow immune cells also will be reduced. Immune cells reduced, easy catch of infection, you can die with a common cold. So we need to be very cautious when we are giving chemo to the patient. Okay. A patient in chemo in the ICU, you just sneeze near them, they will die in 1 week. They are very sensitive because their immune system has been drastically compromised. Okay. Yeah. So if any infections caused, say for example cytomegalovirus or HIV virus will destroy some of the white blood cells, resulting in aplastic anemia. If you treat the HIV, aplastic anemia can be curable. So there are some reversible aplastic anemia conditions and non-reversible aplastic anemia conditions. Most of the cancers are irreversible. Okay, most of the cancers are irreversible aplastic anemias. So that's it. Then coming to this point, bone marrow. Okay, everyone pay utmost attention. We know that bone marrow will produce many types of cells. These cells has been broadly categorized into 2 types: myeloid cells and lymphoid cells. Lymphoid stem cells will produce T cells and B cells. Lymphoid stem cells will produce T cells and B cells, whereas myeloid stem cells will produce all other cells, both granulocytes and agranulocyte. Agranulocyte, that is monocyte. This you already studied in erythropoiesis. Okay, colony forming unit. There is a monocyte, granulocyte, monocyte. Okay. Okay. Now listen. If there is a cancer to myeloid cells, if there is a cancer with myeloid cells, this cancer is called as myeloid leukemia. If a cancer happened to the myeloid cells, that cancer is called as myeloid leukemia. If the cancer happened to the lymphoid cells, that cancer is called as lymphoid leukemia. Okay? Myeloid leukemia and lymphoid leukemia. Now, if this lymphoid leukemia is an acute, then that is called as acute lymphoid leukemia. If it is a chronic condition, that is called as chronic lymphoid leukemia. If myeloid leukemia is acute, then that is called as AML, acute myeloid leukemia, chronic myeloid leukemia. Now I am slowly shifting this lecture to leukemias or cancers. Okay. Even during cancer conditions, you will see an aplastic anemia symptoms. You will see an anemic symptoms in the patients when there is a cancer, because abnormal cells are increasing in the body. Okay, these abnormal cells will suppress the normal cellular functions. I will go to the next slide, then you will understand. So the cancer has been broadly categorized into two. What are those? Acute and chronic, myeloid and lymphoid. Acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia, chronic lymphoid leukemia, or lymphatic leukemia, whatever, right? So this leukemia concept is clear, right? Then next one. I'm just skipping some normal things like bone marrow function, bone marrow cells. I'm not discussing those things. I'm just skipping it. Then there are certain categories of identifying these cancer cells. That cancer cells we'll discuss in tomorrow's lecture. Today I will emphasize on another important topic. That is the cost of bone marrow transplant. The average cost of bone marrow transplant in India is around 15 to 40 lakhs. Okay. Under government scheme. Private it is, I saw in Metropolis and Apollo, it is around 1 crore to 1.4 crores. 1 crore 40 lakhs. Under government scheme, if government sponsoring everything, still you need to pay 15 to 40, 50 lakhs almost. That is the cost of transplantation. Very painful. You all need to be very happy that you don't have such issues. We worth a lot actually. I estimated roughly a human worth around 10 to 15 crores each body. No, we are 15 crores bodies. Don't destroy it. Some of the interesting things. The treatment only takes 3 to 4 hours actually. A 50 lakhs treatment will be finished in a matter of 4 hours. But you will be in observation for next 12 months. Okay, next 1 year you will be under observation for seeing whether the bone marrow has been, grafted properly or not. Yeah. Okay, fine. So this is all about the bone marrow transplantation. You got some idea, right? So my final thing, a simple anemia or a simple CBC report can lead you to some 50 lakh treatment. Now it is clear, right? The significance of hematology. A simple CBC can give us insights of 50 lakh issues. Okay, and 50 rupees report. 50 rupees CBC report can give insights of 50 lakhs issues. Okay, yeah. Then how we will perform this? How we will know whether patient has this cancer or not? Okay, there are some biochemical markers, there are some biochemistry tests we can perform, there are some blood tests we can perform. Some of the blood tests will be CBC only. In CBC we are counting the T cells, all these CBC report we will check. And there is a gold standard technique. The gold standard technique is directly going into the bone marrow. Take a sample of bone marrow, make a smear, check under microscope whether it's a cancer or not. Right? Now, I will discuss about bone marrow aspiration and biopsy. Okay, so in an adults, the sites of obtaining samples of bone marrow are sternum, iliac crest, and from the shaft of the long bones. Okay, from the epiphysis, from the epiphysis of long bone, or from sternum and iliac crest. Iliac crest means that is your hip bone, from back of the hip bone, from here we will collect the sample. And sternum, ideally we won't go with sternal sample, okay? Because if you do any mistake in sternum, that's it. You will punch hole to the heart. Okay? So usually we won't go with sternum. The best approach will be the iliac crest. Okay? Here there is a huge amount of blood. By the way, very interesting thing. Most of the blood is produced not from the limb bones, rather than from vertebra, sternum and scapula. Okay, rather than long bones, all other bones will produce blood. Actually, the proportion. Okay, such as flat bones. Even skull bones will produce blood. Interesting, right? Yeah, flat bones will produce blood. Okay. So yeah. Now, I don't know whether you are understanding this or not. I will go to the next topic. This is a needle. Yes. What is the last one? Long bones. But long bones is least, least preferred. The least preferred is the last, fibia tibula. Okay, the large bones, long bones. Okay, now listen, class. Pay attention. Just imagine taking a very strong needle and inserting into your bone, drilling your bone when you are alive. Keep in mind. And collecting sample from your bone. There is no anesthesia for bone actually. We can give surrounding bone, but there is no anesthesia directly you can give to the bone. And you imagine the patient pain when they are undergoing this test. Okay. Now, if you are collecting fluid from the bone marrow, that technique is called as bone marrow aspiration. If you are collecting fluid from the bone marrow, that means blood from the bone marrow, that is called as bone marrow aspiration. When you are collecting the bone marrow itself, okay, the tissue of the bone marrow, that is called as bone marrow biopsy. Biopsy is performed by Jamshidi needle. For aspiration, we will use a elongated thin needle. I will show what are these needles. Okay.
Sir, what is bone marrow biopsy?
Bone marrow biopsy. In bone marrow biopsy, we will take tissue of the bone marrow. If you are a non-veg, then you will understand, right? From chicken bones, you will suck something, right? That is bone marrow. Exactly, the biopsy form of bone marrow. So we are already doing it, all non-veg people. Okay, anyway, see here. So this is the needle. This is Jamshidi needle, okay? This is called as Jamshidi. This is the spelling. So the idea of Jamshidi needle is there are two needles, okay? I don't know whether I have it. Do you have pen with? Yeah. Listen. This needle has two portions. Okay, there is a inner needle and there is a outer needle. Along with inner needle, first I will punch a hole into the bone marrow. Then I will remove inside needle and I will collect blood from here. Okay. So this is the idea of bone marrow aspiration and the biopsy. I will show you a video, then you will understand. So Jamshidi needle, right? This is Jamshidi needle. There are some differences between a biopsy, aspiration and biopsy. Everything is clear, right? Then let us see this video. Oh, we don't require sound actually. So this is a modified Jamshidi needle. They said they have some elongation. Okay, this is a new company. They are doing these things. So this is a modified Jamshidi needle. Take a Jamshidi needle, and it has a drill bit. It has two portions. You can see here. They are using specialized needles here. So go with the iliac crest. So yeah, there is the iliac crest. You can color from iliac crest, from tibia or from the sternum. Yeah, they are trying to say that this needle has some flexible properties. Anyway, this is an animation. I don't like animations. I will show you an actual video. See here. Yeah, so this is the positioning of the patient. This is called supine position. The patient will be in the fetal position like this. The patient will be turned over on his side, and you can see here. So first we will palpate the iliac crest. So they are identified where is the iliac crest. We will palpate the iliac crest. We mark the iliac crest. After marking the iliac crest, we will yes. This test will be performed by physician actually, doctors guided by nursing and lab technician. Now we need the sample, so we will guide them. First, and clean the area, give anesthesia. Listen, this anesthesia won't work at all in reality. For name's sake, we are giving anesthesia for reducing slight pain, that's it. So we are giving anesthesia at the site of this one. Yes. Attendance class, meanwhile, Jaskaram, Steve.